Hi everyone, my name is Yu Chen. I'm a PhD student at Harvard University in the Department of Global Health and Population. And today I'm going to give a very brief introduction to qualitative research. So let's go back to a typical day in your clinics. The benches are full, the hallway is very crowded. A young man, just 23 years old, is brought into your clinic after a motorcycle crash. He's in shock, in pain, and barely conscious, and his lower leg is mangled, a grade 3C open fracture. You take one look and know that this cannot be saved. You stabilize him, explain the situation, and recommend an amputation. It's the only path forward, the safest one. He listens and his family listen. And then they shake their heads and say, no, I'd rather die rather than losing my lab. So you try to again more gently, explain the infection risk, the danger of waiting, but he won't change his mind and his family won't either. And you realize that he's not the only one, his families are not the only one. You begin to notice other patients making similar choices. People refusing amputation, delaying life-saving surgeries, turning down procedures that could restore the functions or even save their lives. At first, it's easy to focus on the clinical facts, the fracture grade, the vascular injury, the infection risk, but after seeing case after case like this, you start to ask, what are we missing? The problem isn't just medical, it's not just about knowledge or access. The problem lies in the stories we are not hearing right now, the question we haven't learned to ask. This is a great place where qualitative research can come in. It can potentially help us to understand why the patterns keep happening. So there are two types of research we have here, quantitative one and qualitative one. How do we distinguish them? So for quantitative research, it's like a great place to tell us what is happening in terms of numbers. For example, 30% of eligible patients decline surgery. It gives us a brief introduction, brief numbers of what's happening, but it doesn't tell us that why patients are declining the surgery. Some of the most important factors like fear, belief, cultural narratives, mistrust, caregiving burdens, those cannot be captured in numbers alone. Qualitative research help us to step into the patient's world and seeing the decision through their eyes, especially in setting where context, culture, community play a huge role in decision making. Quantitative research tells us what is happening, and the qualitative research can help us understand why this is happening. So in orthopedic setting, we can use qualitative research to explore a wide range of issues. Some examples here, why do some patients delay or decline joint replacement? What are barriers to children with osteomyelitis and their caregiver face in accessing care? What factors contribute to gender differences in hip fracture incidence and outcomes? How do parents experience the burden of care for a child in scoliosis brace? And how can we develop a recovery barrier tool that actually makes sense to our patients? All of these questions here require us to listen to people's real stories, not just to measure their outcomes. So in qualitative research, there isn't just one way to listen or measure. There are different designs for different goals. Let's go in one by one. So the method you choose depends on what you are trying to understand. For example, narrative research, it tells the story of an individual's experience. And phenomenological research, which describes the essence of a phenomenon as the name tells. And the third research design here, ground theory research, which develop a theory from the field, from whatever you're observing. Ethnographic research, which can describe and interpret shared patterns of culture in a group. And last one, the one very common that a lot of physicians do, case study research, which provide very in-depth understanding of a case or multiple cases. Those are some common qualitative research design behind. And here, for each study design, there are some example provided here for you guys to take a brief look and trying to understand what might be a good example, what might be a good design for each of those example. Here are 5 examples here correlated with each of the study design. Okay, it's just like surgery has different tools for different jobs. Qualitative research has multiple ways to collect data. First one, information, which is normally in the form of interviews. It can be one-on-one or in group. And second one, observational. It can this one is more like you watch what's happening in clinics, in wards, in community. There are times you're completely an outsider or just observe the setting. There are also times that you become one of the members in the community. You're observing and try to participate and experience it. A lot of times we sometimes someone have the researchers to pretend to be the patient and go into the clinic to interact with the care provider to understand the dynamics of the interaction, what is happening in the clinics. So that will be one of the example of the participatory observational study as a way to collect data. And third one, document reviews, which include review document of patient records, policies, reports. And last one is community-based participatory techniques. Photo voice will be one of the example here. For example, you want to understand the dietary patterns of kids, of the patient, and then you ask them to take a picture of the breakfast they eat and record them down and do that repetitively for a few days and keep sending those to you. So you want them to tell the story by the photographs they take themselves. So there are times you just use one technique that's enough for answering your research question. There are also times which you choose combination of a few. So among this four methodology, I would like to focus on the information one, since this one is very commonly used and contains specific procedures for how do you conduct interview with a group or with individual. So it's normally done in the format of in-depth interview or focus group. In-depth interview will be the one you conduct individually with the participant, and focus group, you bring a group of people together to discuss a problem. And now I'm going to go into a little bit more details about those two. So let's talk about in-depth interview, or the abbreviation for that is IDIs. So think of in-depth interviews as your chance to scrub in, not for an operation, but for a conversation. Instead of cutting through tissue, you're cutting through assumptions, getting right to the heart of a patient's experience. We use IDIs in depth interviews when we need to explore something more complex, emotionally or sensitive, and they are ideal when we want to understand an issue through the patient's own lens, whether it's their pain, their fear of surgery, or they perceive the quality of care. This is a one-on-one conversation, private, focused, and personal. The questions are open-ended and flexible, more like a guided discussion than a script. It usually takes about 30 to 60 minutes, but the real magic here is that it comes a lot of times the answers come in surprise form. Those unexpected insights that change the way we think about the problem and we think about what's happening in the clinics. And if we think in-depth interview are like one-on-one clinic visit, then focus group discussion are like a word round or team meeting. The real value comes from the interaction between or among people. We use focus group or FGDs to explore group beliefs, perceptions, and interactions. The goal is to hear the shared views, but also to notice the differences on a specific topic or intervention. The magic of an focus group is in the group dynamic. One person's story sparks another's memory. Someone disagree and the discussion unfolds. That's when you get insight into how people think together. Focus group really bring together probably around 4 to 10 participants, guided by a moderator who keeps the discussion flowing and supported by an observer or note taker to capture what's said and what's not said. Session can potentially last 1 to 2 hours, and they are particularly useful for testing ideas or evaluating programs. In short, focus groups don't just give you an answers, they give you the conversation that produces those answers. We have now looked at in-depth interview, IDIs, and focus group discussion, FGD, separately. But how do you decide which one to use? So this side-by-side table here help us compare their strengths and limitation. In terms of strengths for in-depth interview, they're best used when you need privacy, when you need depth of a conversation. They reduce peer pressure and create a safe space for people to share personal stories, like fears about surgery or struggles during recovery. They're also flexible. You can follow up and dig in if you find the response interesting or insightful. In terms of strengths for focus group, they're very great when you want interaction, as we mentioned earlier. They're great for brainstorming, exploring group dynamics, and understanding both shared and differentiating experiences. The discussion often sparks ideas that wouldn't come up in a one-on-one conversation. And in terms of limitations for those two methodologies, for in-depth interview, it can be resource heavy and time consuming. Plus, responses can be influenced even unintentionally by the interviewer's tone, assumptions, or relationships with the participant. And limitation for focus group here, they're on the other hand, not ideal for very sensitive or deeply personal topics. In a group, people may hold back if they feel like they were judged or uncomfortable. So the choice isn't about which method is better, it's about matching your method to your question. If you need depth and privacy, go with IDIs. If you want interaction and group insight, choose focus group, or sometimes use both for a richer picture. So far we have talked about what and why of qualitative methods. Now let's look at how. Conducting an in-depth interview or a focus group is not as simple as just sitting down and chatting. It's a very structured process, and much like prepping for a surgery, every step builds on the one before it. So the first step here we want to look at is determining a research question. We start with a clear, focused research question. What do we want to understand that numbers alone cannot tell us? It might be grounded in your own clinical experience, but haven't answered by current literature yet. And then the second step, identify participants. Once we know what we have studied and what we decided who we need to hear from, participants should have direct and lived experience of the issue, whether that's patients, caregiver, or health workers, and you find ways to identify those participants. And then next, we chose the format. Will the interview be one-on-one or in a group, face-to-face or by phone call? So that's how we think about the different types, modes of interviews. And then you need to design a topic guide, which is a very flexible guide you draw down for the question you want to ask. It's not a script, but it's just for the purpose of guiding you for asking to going through those questions designed to spark conversation and explore what matter most to the participants. So you have something in hand and consistent across different people. And in terms of training, it's not just anyone doing the interviews, but we want to train staff to ask questions without leading, to listen deeply, and to respond respectfully. The step ensure we are collecting high quality and ethical data. And then finally, we want to identify an interview setting where we conduct interview really matters. We do not want to just conduct interview in the middle of a crowded waiting area because we really want to respect the participant who are coming to the research. So we aim for a quiet, private space that allow participant to freely speak without distraction or hesitation or fear of being overheard. And before we do the interview, we need to obtain consent from the participant. You need to explain what the study is about. The this study is totally voluntary. It's not tied to their case or the hospital bill. You give space for their questions. We have to get a signed consent from participants before the interview or focus group start. And again, their participation should be completely voluntary to the study. And lastly, you want to pilot and refine the topic guide you developed after a few interviews. You start with a few with the one you designed before, and then after the first few, you realize that okay, many patients they mention topics that you didn't think about before, but really worthwhile to dig in more. So you will go back to revise the guide, the prompt, you have all the question, and then you can better prepare for your future interviews based on the existing one, and your interview guide evolves. This process is not just a linear one, it's very iterative. You might go back and forth to refine your guide again and again after hearing something unexpected. That's the strength of qualitative work. It grows with the data. Through this process, you're not just collecting opinions, you're understanding the real world context shaping orthopedic outcomes. To wrap up quickly, so today we have gone from the clinic to the community, from understanding what's happening in our practice to uncovering why it's happening. We went through different design of qualitative research and methods for data collection. We focused on interview method, which include in-depth interview and focus group discussion. We have seen how in-depth interview give us privacy and depth, and how focus groups bring group energy and shared perspectives, and how choosing the right methodology really depends on the question you're asking. And we have walked through the step-by-step process, just like prepping for surgery to make sure our qualitative research is structured, ethical, and meaningful. In the end, qualitative research isn't separate from what you're already doing as a surgeon. It's an extension of your skills. You're already listening to patients, to their stories. This simply gives you the tools to listen better, capture their voices, and use those insights to improve care in a systematic way. So at the end, I want to acknowledge Dr. Akbar Harden for guiding us, organizing the session, and also special thanks to Professor Yusuf Zay, based at the School of Public Health, for providing training for a lot of qualitative research, and of course, many members from the organization to help us to make this course happen. And thank you very much for listening.